Our ASH 2015 coverage continues in Orlando. I'm Thomas Baldrick, joined now by Dr. Anthony Stein. He's from the City of Hope Medical Center in California. Thank you, sir, for taking a couple minutes of your conference for us.
No problem.
Let's talk about this phase 1 trial you have for trying to help AML patients. Why is 33A an appealing agent for them?
In AML in general, CD33 antigen is expressed on the surface of AML cells in over 90% of cases. This particular antibody, as opposed to prior antibodies, is an engineered humanized antibody. Because of its construct, they are able to attach two molecules of the chemotherapy agent, which is a very potent agent that interferes with DNA repair consistently to this antibody. Because of the linkers where the drug is conjugated to the antibody, the drug itself, which is a very potent drug, is not released into the circulation, and it only gets released into the leukemic cell once the antibody is internalized into the leukemic cell. So it's basically like a smart bomb.
Okay. How did you try to use this smart bomb in your study?
So in this study, the study started off trying to find out what the optimum dose of the antibody that could be given in patients with relapsed leukemia or in older patients who declined standard induction therapy.
What did you find?
So far, we've defined the dose that can be safely given as a single agent, which is 40 micrograms per kilogram. The drug is given as a single IV injection over 15 minutes. If the patient is stable enough, this can be given in the outpatient setting. And so far, just looking at the patients who received the 40 microgram dose, the CR/CRI rate is around 45%, and so we define response rate basically on complete remission, meaning no less than 5% blasts present when you look at it under the microscope, and then there's the white count, the neutrophil count and platelets recovered to normal. The other definition is a complete response, but with incomplete platelet or neutrophil recovery. In this case, the patients who fell into the latter definition, those patients never recovered, they had delayed platelet recovery. But when we tested them at a deeper level, measuring their minimal residual status, approximately 80% of the CRI patients were MRD negative. So this probably means that these patients who are classified as CRIs, the reason that their platelet count is probably not returning to normal is more related to the drug rather than having persistent leukemia still present.
How will you be proceeding with this research?
So whenever a drug is developed, it's first looked at in more patients with advanced disease, or in the case of AML, in the older population, because there is no good therapy for these patients. So now future trials are basically going to be adding the antibody to a hypomethylating agent, and that study was actually presented this morning in an oral session, and those results are actually looking very promising, especially in an older population of patients.
How so? What's a highlight?
So the drug has been combined with azacitidine or decitabine and the CR/CRI rate for that combination is around 65%, which is much higher than what you would see just with the hypermethylating agent alone. The median age of these patients are in the mid-70s. I think the oldest patient that was treated is 89. So this is a therapy that can be given to older patients, relatively well tolerated. So far the results are looking promising, but obviously we need longer follow-up to see if these responses are durable or not.
Very good. Thank you, Dr. Stein. Appreciate your time.
All right, no problem.